you all. I am Dr. Vinita, finally an MD postgraduate from Coimbatore Medical College. Today, I am going to present a clinical case scenario under the guidance of Professor Dr. M. Geethanjali ma'am. First of all, I would like to thank my beloved HOD ma'am, Professor Dr. V. Booma ma'am, for giving me this wonderful opportunity. Coming to the case, 11 years old girl child, Tulasi, firstborn child of second degree consanguineous marriage, coming from Tirupur, brought by mother with good reliability, with complaints of pain and swelling over the right knee joint for the duration of 15 days prior to the admission, and had a complaints of fever for 15 days duration, and history complaints of cough for 3 days duration, and complaints of breathing difficulty for the duration of 2 days, 15 days prior to the admission. History of presenting illness. The child was apparently normal until 15 days prior to the admission. Then she had developed joint pain for the duration of 15 days. Pain and swelling over the right knee joint, which was acute in onset, relieved by medication, which was a fleeting type of pain associated with restriction of movement, resolved completely without any deformity. Following this, child developed pain over the left knee joint, then to the right knee joint, and history of there is no history of morning stiffness, and there is no history of small joint involvement. And history of fever for the duration of 15 days, which was high grade in nature, intermittent type of fever, relieved by medication, not associated with chills or rigor. Interfebrile period, child was active. And there is also history of cough for the duration of 3 days, dry cough, aggravated on lying down, no diurnal variation. And there is a history of breathing difficulty for the duration of 2 days, breathing difficulty present even at rest. According to New York Heart Association, it comes under class 4, which was aggravated on lying down and relieved by sitting posture. And there is a history of orthopnea present. There is no history of paroxysmal nocturnal dyspnea. And history of chest pain present for the duration of 2 days over the precordium, which was pricking type of pain, not radiating, aggravated by exertion and relieved by rest, not aggravated by deep inspiration. There is a history of easy fatigability present, and there is a history of edema of both feet and legs up to knee joint. There is no history of facial puffiness or reduced urine output or hematuria. There is no history of palpitation or syncopal attack. No history of rashes or swelling over the bony prominences. There is no history of any painful fingertips. No history of frequent falls or dropping of objects or emotional lability or deterioration of handwriting. There is no history of vomiting or abdomen pain. There is no history of bony pain or epistaxis or bleeding tendency. No history of loss of weight or loss of appetite. No history of turning blue or squatting episodes. Coming to the treatment history, for the above complaints, child was initially taken to a private hospital and treated with antipyretics. In view of breathlessness, child was referred to our CMCH. And CMCH, child was received in an impending respiratory failure state. In view of impending respiratory failure, child was intubated and started a mechanical ventilation. Child was on mechanical ventilation for the duration of 3 days. After that, weaned off from ventilation and switched over to oxygen through nasal cannula along with IV medication and kept under strict bed rest. Coming to the past history, there is a history of sore throat in the past, 1 month back. For that, child was treated with oral medication. There is no history of recurrent respiratory infections in the past and no history of any chronic drug intake. Coming to the antenatal history, she is a firstborn child of a 21 years old preemie mother, conceived 1 year after marriage, and booked and immunized at Tirupur GH with regular antenatal visits. She took iron and folic acid tablets from the second trimester. 3 antenatal USGs were done, and anomalies can also done, all said to be normal. There is no history of pregnancy-induced hypertension or gestational diabetes or anemia complicating pregnancy, and no history of any chronic drug intake. Natal history, she born through a full-term normal vaginal delivery with the birth weight of 2.8 kg, cried immediately after birth with smooth neonatal transition, and started on breastfeeding immediately after birth. She was on exclusive breastfeeding till 6 months of life. Postnatal histories were uneventful. She is a developmentally normal child studying in 6th standard with good scholastic performance. She is immunized up to 10 years of age as per universal immunization program. No additional vaccines were given. Coming to the diet history, She's taking mixed diet, which was deficient in micronutrients. She's taking 1,700 kilocalories. The required for her age is 2,060 calories. Here the deficit is 360 kilocalories. She's taking 24 grams of protein. The required amount is 27 grams with the deficit of 3 grams. Coming to the socio-economic history, she belongs to a lower middle class family according to modified Kupusamy scale. It's a 4-member nuclear family, lives in a semi-pakka house with 1 room with no windows. Overcrowding was present. Using separate toilet facility and using corporation water, nearby health facility at 2-kilometer distance. Coming to the family history, there is a history of fever and joint pain in father at the age of 10 years, for which he was treated with monthly IM injections up to 21 years of life. Contact history, there is no history of contact with known TB or COVID-19 cases. Coming to the summary of the history, this 11-year-old girl child, she is a first-born child of second-degree consanguineous parentage, developmentally normal child, immunized up to the age as per universal immunization program, belongs to a lower middle-class family, a lower economic, socio-economic status, admitted with impending respiratory failure with immediate antecedent history of migratory polyarthritis with fever of 15 days duration, followed by cough, orthopnea, dyspnea or class 4 dyspnea and orthopnea, along with bilateral pedal edema with significant past history of sore throat. Probable system involved here is cardiovascular system. Probable etiology being rheumatic etiology with signs of congestive features of congestive cardiac failure.
Before she proceeds to general examination, can we ask her a few questions?
Yes, ma'am, that's the routine. I think analyzing and understanding the history is very important before even we go to the examination, because we should know what we are going to look for.
Yes, sir.
So please go ahead. Please go ahead and just ask questions.
Okay.
Excuse me, I would like to ask one question. Dr. Ramesh, one of the judges. Vinitra, you didn't talk about any native medication, because it is customary when they have joint pains, they apply some oil and rub it. Was there any history of family medication? I mean, home remedies or oil application, massaging?
No, sir. She was taken to a private practitioner. They prescribed some oral medications.
Okay. No external application was done.
No, sir.
No, you must also talk about relieving factors and aggravating factors. What are the aggravating factors in this patient and what are the relieving factors?
Whenever she takes that oral medication, she able to feel that there is a reduction in pains. After a few hours later, again she got pains. Aggravating factors are movements. While moving the joints, she feels the extreme pain, and pain was severe in the form of even touching of cloths also causing the pains.
Exactly, that's what I'm trying to point out. Even rubbing, even a touching of blankets or dresses also produce pain. You mentioned there is overcrowding. You didn't mention about the toilets. It's also important. And also whether it is a rural poor or urban slum.
She mentioned about toilets. She mentioned about toilets. Yeah.
Okay. About
is
whether
that family history? Is that family history significant in father? What is the recent thinking regarding the positive family history, dramatic setting?
There is a significant association between the HLA DR 2, 3, and 4 with DW10 mutations will have the recurrent family history of rheumatic fever.
Okay. Yeah, they have found out that the incidence in monozygotic twins is more when compared to the incidence even in dizygotic twins. So that made them think about the multifactorial inheritance of the disease.
Can you please describe orthopnea and PND? What is your understanding and what is the mechanism?
Now, orthopnea, when the child lies down, immediately after lying down, child getting breathlessness. In paroxysmal nocturnal dyspnea, after 2 to 5 hours of lying down, child getting dyspnea, which was relieved at 20 to 30 minutes after getting up from the bed. In orthopnea, child is able to feel improved immediately after getting up from the bed.
What is
The question was because you repeated both. You said child felt better by sitting up than by lying down. And the next line was history of orthopnea present. Both meant the same.
Same.
Just go back to your history, you mentioned that. Yes, Dr. Vinod.
sorry, what is the mechanism? You did not tell me the mechanism of orthopnea and PND.
Yeah, and the orthopnea is mainly due to two causes. One is due to while lying down, increased venous return to the heart. So that causes the in case of failing heart, there will be shifting of fluid from the interstitium to the intravascular space. That will causes the volume overload. And another thing is elevation of the diaphragm while lying down.
Right.
In
That is
paroxysmal nocturnal dyspnea, there will be increased sympathetic activity after lying down due to decrease in the PaO2 levels.
no, actually in PND after 3 to 4 hours you told you get dyspnea, right? So when he goes into REM sleep, which happens after 3 or 4 hours of sleeping, then sympathetic stimulation decreases. So these patients are compensated because of sympathetic stimulation. So when the sympathetic stimulation decreases after 3 to 4 hours, the patient goes into heart failure more. That is why he wakes up after 3 to 4 hours of sleep and then catches his breath, goes to the window to catch his breath. So that is a mechanism of TND. So what do these two symptoms signify in your case? There is what?
There is evidence of congestive cardiac failure.
Left or right heart failure?
Left heart
Specify.
failure. Left heart failure.
Correct. So in your summary, you had written impending respiratory failure. I felt it just if you were told that patient had heart failure itself, it would have been much more better. Admitted with heart failure, that's all. You don't have to write impending respiratory failure, just admitted with heart failure. Then with the immediate antecedent history of migratory problem, which you have written.
Okay.
Okay.
History of involuntary movements should be mentioned, isn't it? Have you made a mention of negative history?
She mentioned, madam.
You mentioned,
I
madam.
mentioned about emotional lability and poor scholastic dropping of objects and poor scholastic performance. Deterioration of scholastic performance.
You mentioned fatigability, no? So what does that indicate in this case? From a pathophysiological point of view, you wrote fatigability. What does that mean? It's definitely a significant symptom.
Because of congestive cardiac failure,
Can you be
hypoxia.
more precise?
In your congestive cardiac failure, the metabolic demand could be met in this child.
No, basically, if you have fatigability, it means there's low cardiac output. So if there's low cardiac output, there'll be easy. Not all patients with heart failure will have fatigability. So if in a heart failure, in any case where there's low cardiac output, you will have fatigability. So that is the significance of fatigability. Do you understand?
Yes, sir.
Okay. You mentioned epistaxis. What is the relevance in this case?
The atypical presentation of rheumatic fever can present as epistaxis in 5 to 10% of cases.
So what are the other atypical presentations, you know?
Anemia, epistaxis, recurrent abdomen pain, and rheumatic pneumonia.
Very good. Very good. Okay. What about significance of chest pain in this patient?
Sir, since in case of aortic valve involvement, there will be a chest pain on exertion. Sir.
Okay. What is the mechanism of that? Why do you get that? You are correct. So what happens to the pulse pressure in aortic regurgitation?
White pulse pressure.
So coronary is at, so that means diastolic is low, right?
Yes, sir.
So coronary
Coronary
perfuses in systole and diastolic.
During the diastole.
Correct. So that's why you get a demand supply mismatch. So it's a myocardial ischemia. In fact, patients with aortic regurgitation will have something called as nocturnal angina. So during sleep, due to the bradycardia which happens, the diastolic pressure decreases even more, and then they're prone to having angina more in the night. What are the other causes of chest pain in your case? You said one. Any other cause, you know?
If there is any pericardial involvement, there will be a pain.
Very good. So can you differentiate the pain of pericardial involvement and what you said, myocardial, this AR, myocardial ischemia?
In pericardial myocardial involvement, there will be a
Not myocardial,
exertional.
not myocardial ischemia. In that, how will the pain be, and how will the pain be in a pericarditis? So basically, myocardial ischemia, it will be like a pressing type of pain, more on exertion and relieved by rest. Okay. Pericardial pain will be, as you said, can be a pricking type of pain, can aggravate on deep inspiration. Okay, and is relieved on sitting up and and bending forward, and it is relieved by bending forward and increased by lying down. And pericardial pain can also increase on deep inspiration. So these are the two types of pain which you can get in rheumatic fever, and how to differentiate both.
What will be the symptomatology if there is a valvular or endocardial involvement? We talked about pericardial involvement, myocardial involvement. If there is a valvular involvement or endocardial involvement, what symptomatology will be there?
No, the question is, rheumatic carditis is supposedly a pancarditis. Of the three things, most common is valvulitis, and then valvulitis plus myocarditis, and the least common is valvulitis, myocarditis, and pericarditis. Okay, all the three are seen maybe less than 50%. And the question is, how will you know that the child is having valvulitis?
From
That's what he
symptoms.
mentioned as endocarditis. Yeah. What symptom the child will have if it is a valvulitis? As you mentioned, what does valvulitis do? What does it do? It causes regurgitation. Okay, valvulitis causes regurgitation, and the symptoms of heart failure means child is having valvulitis. Okay, and generally the myocarditis in rheumatic fever differs from myocarditis from other etiology, where the LV dysfunction doesn't occur. LV function is normal. So the heart failure, if we have symptoms of heart failure, it is because of valvulitis. Myocarditis is just a biochemical, microscopic finding. It does not cause LV dysfunction and it does not cause heart failure. Of course, pericarditis causes pain and pericardial effusion. Okay. Now, I just want to ask, is this a real true case, or you kind of created a case for the sake of presentation? Is it a true case? Because it's a very, very classical kind of signature case. So can you go to the first slide? We'll go by one slide. Go to the very first slide. Okay. Okay, next slide. See, now here regarding a joint pain, and when you want to mention the joint pain as rheumatic and non-rheumatic, either it should be fleeting type of migrating chest joint pain or additive kind of pain. Most of the other causes of joint pain in children, they all come together and go together. Okay, and you very classically said she had involvement of one joint and subsequently the other joint was involved. This history practically rules out all other differential diagnosis for joint pain in children. Okay, so we do not have anything to discuss further on joint pain. So whenever you have joint pain and dyspnea, we may give some differential diagnosis. But this one history is so clear-cut and very particular about rheumatic fever that we don't have anything to discuss here. And you said there was resolved completely without any residual. This is very specific term. You can say that it resolved completely. Don't mention without any residual problem, because that comes only after the examination. Okay. So there was severe pain, but it disappeared and we resolved completely after the child had another joint involvement. And you were mentioning here for morning stiffness and other things, small joint involvement, to tell that it is not rheumatoid or some other kind of, that's fine. Okay, next slide. Now, this high-grade intermittent read by medications, not also chills and tigers, there is no particular pattern of fever and rheumatic fever. So whatever you mention is fine. Fever could be mild, fever could be very high grade also, fever could be intermittent, fever could be continuous also. Okay. And interfebrile period child was active. What is the importance of this line?
Actually, if the child is active in between interfebrile period, probably could be a viral etiology.
So exactly. See, the thing is, when somebody has a bacterial septicemia, even during interfebrile period, child will remain sick, child will remain dull, child will remain inactive. Whereas a viral fever, at the time of fever, he'll be so kind of, dull, lying down. Once the fever goes off, they will be sweating, he starts playing. But rheumatic fever doesn't occur like that. Rheumatic fever, the pain will persist. The overall general body fatigue will persist. As Dr. Vinod said, the easy fatigability will be there. So this line may not be matching with your other history. Okay. History of cough, again, you said aggravated on lying down. And what do you mean by aggravated on lying down cough?
In case of any pulmonary edema, there will be
cardiac
aggravation
cough.
of
Okay, so increased pulmonary venous pressure, and it's a cardiac cough. Okay, lung related cough may not have this specific history. Okay, so next. In children, we need not use the NYHA class. You can just mention whatever is happening. So as I said, it's aggravated on lying down, read by sitting posture. It's a classical description of the orthopnea. So the repetition of history of orthopnea again need not be repeated. When somebody has orthopnea, the history of PND is irrelevant, isn't it? See, PND has to come before the occurrence of orthopnea. If somebody is already having orthopnea, the history of PND is irrelevant. Chest pain is a very important topic in children. Dr. Vinod has reasonably kind of described. It's a very rare finding to have a child to complain chest pain. Myocardial ischemia causing chest pain is practically not seen in children, even in Kawasaki disease. The patient may have actual coronary artery disease, but chest pain is rare somehow. So you take alcohol, say disease of infant, they don't come with chest pain. The child cannot complain of chest pain, but chest pain otherwise, if you take the causes of chest pain in children, pericarditis is the cause of actual cardiac pain. Okay, pericarditis will not be aggravated by exertion, will not be relieved by rest, as rightly pointed out by Dr. Vinod. It will be there all the time. Aggravated by respiration, because at that time the pleura comes and rubs over pericardium, and hence the pericardial pain will be aggravated during inspiration, deep inspiration, and relieved by, most of the time these children will have a shallow breathing. A pericarditis pain will have tachypnea, but there won't be distress of the breathing. There won't be respiratory distress, but there will be tachypnea, just to avoid the catchy pericardial pain. Okay, next. History of easy fatigability, again, Dr. Vinod has said, it's an inability to increase the needed cardiac output. Somebody has, say, cardiac output of, say, 3 liters, and he starts going for a walk. Now it has to increase to 4 liters. He cannot do that. So he'll get tired and he'll just sit. It's not heart failure. It's a forward failure. Okay, it's a kind of, you can say heart failure. It's a forward failure. There is inability to increase the stroke volume as per the need. That is the reason for this easy fatigability. Okay. Now, you can, for the completion's sake, you are telling about edema, facial puffiness and all. Generally, these are rare in children. You should remember, these are rare in children. And if these things occur, they indicate that there is additional right heart failure. So whenever you give the history can be initially divided into all left heart failure symptoms. No history of dizziness, no history of syncope, indicating there is LV outflow obstruction. Okay. So orthopnea, PND, chest pain, all are predominantly left side symptoms. When you come to the right side symptoms, you can know facial puffiness, no inguinal neck pain, no abdominal distension, no pedal edema, to say that there is no right heart symptom. So these two can be go kind of separately told. You will tell initially the left heart symptom, then you tell the right heart symptoms. Then you can tell history of complications separately. What intermittently you are telling some history of complications here and there, painful tips, and history of etiology, history of rashes is coming, history of swelling over prominences is coming. That's history of etiology. So history can be divided like initially presenting complaints, explaining the presenting complaints. After explaining the presenting complaints, all left heart symptoms present or not, or right heart symptoms present or not, then history for etiology, history for complication, then history of etiology. If you go in this order, all the cardiac patients, I mean, you can cover almost all the You won't be missing anything. Rather than routinely mentioning everything, we can be very specific. Okay, next slide. Now here, history of turning blue splatting episodes are redundant, isn't it? It doesn't mean any meaning. You can completion say you can write, but makes any meaning, no meaning. And impending respiratory failure, Dr. Vinod, I think that's a right term only to use, because the child was about to go for a respiratory arrest and child was intubated and ventilated. Yeah, impending respiratory failure need not mean respiratory disease. It can be respiratory disease or cardiac disease. One of the panelists has asked, how do you say that it is a cardiac related thing? How are you so sure that it is cardiac, not respiratory? Obviously, she has mentioned all only cardiac symptoms. The very classical history of having edema, history of orthopnea, when these things are there, the first thing which comes to mind is a cardiac problem than the respiratory problem. Okay, and she was on IV medications and things like that. Okay, next one. Next slide. What is the importance of sore throat in this case? History of sore throat, you said there is a sore. Can you pick up a child whose mother doesn't say there was no sore throat? So practically every children will be having some kind of sore throat. Okay. So presence of sore throat doesn't help us in the diagnosis of rheumatic fever. Absence of sore throat doesn't rule out rheumatic fever. Okay, if it is there, you can just mention. And history of sore throat present 1 month before may not be taken as a point supporting the diagnosis of rheumatic fever. No history of recurrent respiratory infection. I just like to add that this history is commonly asked for those children who are supposed to have left to right shunts and increased pulmonary blood flow. And it's better to mention that there is no history of recurrent pneumonia or hospitalization for respiratory infections. Recurrent respiratory infection is such a common thing in children, isn't it? If you ask again any mother or any child, everybody will say yes. So the respiratory infection should be severe enough to need hospitalization, or that should have been diagnosed as pneumonia. In that case, one can give weightage that is kind of predisposed by the increased pulmonary blood flow. So here we can be more specific. No history of drug intake is fine. Next.
Nitra, I have one more question. What percentage of children give history of sore throat? A significant sore throat. If there was a significant sore throat, definitely there should have been high fever, jugular digastric node involvement, pain during eating or swallowing. What percentage of children give this history in rheumatic fever? And what is the time interval between the history of sore throat and the presenting joint symptoms?
See, what's the gap? You said there is history of sore throat 1 month back, isn't it? Okay. Okay. Is it, suppose if I say that this current problem is because of that sore throat, is it right or wrong? Is the question Dr. Ramesh is asking. So what's the gap between the period of infection and the occurrence of rheumatic fever? Is it 1 week? Is it 3 days? Is it 10 days? So what is the usual? Usual?
2 to 3 weeks.
21 days.
Yeah, usually 2 to 3 weeks.
3 to
minimum
6
period.
weeks.
Yes, sir. Dr. Ramesh, please go ahead, sir.
She can present, continue.
Yeah. Okay.
Sorry,
So
one
now
more.
here in the antenatal history, again, if you are going to kind of say it as congenital heart disease, all these things are important. Otherwise, you can, rather than reading it out, you can say nothing significant in the antenatal history. Okay. Next, you
Sir,
can write it down.
Sir, can I ask?
But yes, sir. Please.
No. Yes. Ramesh sir asked second question. How many people will give a?
Yeah.
So,
What percentage of patients with rheumatic fever give history of sore throat?
30%.
It's 10 to 30%. It's such a low number. 10 to 30% only give history of sore throat, and hence presence doesn't favor, absence doesn't rule out acute rheumatic fever, but that history we have to ask for. Okay. Next. Okay, next. See, this dietary history we have been kind of asking for all the children, and if you ask your own diet history, and it will be deficient in many things, isn't it? And I just want to ask, how did you calculate the protein requirement of this child? What is the need of protein per day. Whatever you mentioned was a per day or per week or per month or how much? Just go back to that table. Go back to the table. Yes. Now here you mentioned 2060 calories for per day, I assume. This 27 gram is per day or what?
Yes.
Per day.
Tell.
So what is the dose
Per
of
day.
protein per day needed?
1 gram per kg per day.
1 gram per kg.
Exactly. Okay. So minimum 1 gram per kg. Now it's difficult. I found that 24 grams is a very big number. Reaching 24 gram even for adult is difficult in our current. If somebody is eating idli in the morning, rice in the afternoon, and dosa at night, he is protein deficient. Like whoever are sitting here in this virtual room are all protein deficient. Reaching 24 gram is very difficult. How did you reach? How did you calculate that the child is taking 24 grams of protein per day?
Asking the actual foodstuffs.
Can just for my own understanding, how that means the child is really well fed. If the child is getting 24 grams of protein, that means the calorie also will be equally higher than that. That's what I'm trying to say. Because to reach the 24 grams of protein, especially when the child is predominantly on vegetarian meal, okay, if the child is predominantly on vegetarian meal and this 24 grams of protein was obtained by vegetarian meal, then his total calorie intake will be nearly 3000, going by my calculations. Okay, you can recalculate it just for the sake of stimulating some interest in this topic. You can go to the next slide.
Before Vinitra proceeds, I want one more question.
Yes,
Which
sir.
vitamin deficiency can produce cardiac involvement, cardiac failure? Because you should know about why. Sir has rightly pointed out, you should know all the history and you should know every question that you are asking. You must say why. Have you heard of what is it called? Very good, excellent. Go ahead.
The history of family history, Madam asked, yeah. Madam asked about the history of importance of family history. Now here they live in the same socioeconomic status. That's a common reason for rheumatic fever, though there is some link, but more commonly it is the same socioeconomic status. There is no specific kind of inheritance attached to this one. So now, when you summarize, you can say that this 10-year-old child has history suggestive of rheumatic fever, which proceeded to develop heart failure, and probably was admitted in pulmonary edema with impending respiratory failure, mechanically ventilated, and after a period of 7 to 10 days, he has become clinically stable. Okay, that much we can say by history. If somebody asks, can you have a differential diagnosis? You should say no, because practically I can't think any differential diagnosis, because that's why initially I asked, is this a case prepared for the sake of presentation? It's an actual case. If it's an actual case, then it is a clear-cut kind of signature case. Yeah.
Vinitra,
Okay,
one more question. What will be the interval between the onset of the joint pain and cardiac involvement? What should be the minimum time interval? Or is there a minimal time interval? Both can occur together.
Both can occur together.
Okay, if it's an established heart disease, rheumatic heart disease, what should be the interval between the onset of rheumatic fever and established heart disease? Or in other words, how will you differentiate clinically whether it's an established rheumatic heart disease or it's only a myocarditis, pancreatitis, rheumatic carditis?
I just cleared the question. The child has come with heart failure, right? Is it an pre-existing rheumatic heart disease, and now what the child has come with is a reactivation of rheumatic fever, or is it a rheumatic fever with a current valvulitis related heart failure? So when some child has an acute rheumatic fever, how long does it take for the child to develop rheumatic heart disease, so that next time when you come across the child, you can have both the possibilities, that either it could be a previous rheumatic heart disease with rheumatic reactivation, or it's a rheumatic fever with the first kind of heart disease. That's what the question is.
From my history, it's acute rheumatic fever presenting with valvulitis, because no previous history of rheumatic fever in the past, and no history of any evidence of heart disease or involvement of valvulitis in the past. So,
but there is a possibility that there could have been a subclinical rheumatic fever some time back. Okay, so there is a possibility that there could have been a subclinical rheumatic fever in the past, and currently there could be a worsening of the pre-existing rheumatic heart disease, which you cannot rule out by clinical, I mean, echo or even, sorry, by history or by even clinical examination. That has to be there in the mind. Now the question is, the gap has to be a minimum of 3 years. Following acute rheumatic fever, it takes 2 to 3 years for the child to develop rheumatic heart disease. If you say child will develop rheumatic fever only around 2 to 3 years of age, before that rheumatic fever is very rare. Okay, and then
one
another
more thing. Sir,
yes, sir.
proceed, sir.
Yeah, and then another 3 years for the rheumatic heart disease to occur. That means you are going to commit the word called rheumatic heart disease only in a child who is 6 years or more.
Okay.
If some child comes before less than 6 years, before committing it as rheumatic heart disease, you have to be very sure. That could be only a rheumatic fever with actual valvulitis.
This is something I wanted to highlight. And when in doubt, you have to go by investigations only. You cannot go by history or just physical examination alone.
Exactly. Now, again, before going to the history, now if it is acute rheumatic fever and then the heart disease, what cardiac lesion are you going to expect now?
Involvement of mitral valve involvement.
I mean, what form of mitral valve involvement?
Specify.
Mitral regurgitation.
Mitral regurgitation. Okay, and clinically, if you are finding mitral stenosis, is it possible in acute rheumatic fever?
Juvenile mitral acute rheumatic fever, it's not possible.
No, in this case, I'm saying, in this case, suppose you are getting mitral stenosis.
It's a reactive.
Then what are you going to commit this as?
It's
a rheumatic reactivation. Okay, because mitral stenosis has to be, it doesn't occur under rheumatic fever. It is a chronic process of inflammation.
Think of the pathophysiology.
Exactly. So
correlate the pathophysiology.
Yeah, if you have valvular lesions, AR and MR, then you can commit that it's only acute rheumatic fever. If you have stenotic lesions, AS and MS, better not to commit as acute rheumatic fever related heart failure. Rather, it's a reactivation. These are
as Madam asked, she has to relate to the pathophysiology.
Pathophysiology.
Yeah.
What is regurgitation due to when you see the pathophysiology, and what is the stenosis due to, speaking in pathological terms?
Regurgitation due to the valvular involvement because of either involvement of cardiac engine rupture or else shortening of
no, the valves, actual loss of valvular substance happens. Exactly. And the valves become bulky and they cannot co-opt. But actually fibrosis, cannot approximate. Whereas fibrosis sets in only, you get mitral stenosis, which is a chronic affair.
There is also the sloughing of the valves and valvular edema that prevents the appropriation.
So, acute rheumatic fever, mitral regurgitation can occur because of edema of the cardiac tendineae causing malfunction, because of the edema of the valves causing poor coaptation. It is possible that during acute fever, some child can have a moderate to severe MR. Once the acute rheumatic fever goes away, the MR could come down to mild to moderate. That's very much possible. But it's also possible, as Madam said, if there is a significant destruction of the valvular tissue, curling of valves because of the severe inflammation, the severe MR will remain a severe MR. Okay. Okay. Please go ahead to the clinical examination.
Dr. Vinitha, one question. Is there any relationship between the severity of carditis and severity of arthritis? Like, are they directly proportional, inversely proportional?
No, sir. Inversely proportional. So severe, if arthritis is severe, cardiac involvement will be less than.
Very good.
Shall I proceed, sir?
Yes, please.
Coming to the examination part, general examination. Child was examined on the day 15th of admission. On examination, child was conscious, oriented, afebrile, pallor was noted. Child was tachypneic and dyspneic. Child was on O2 support through the high flow nasal cannula. There is no cyanosis or clubbing or icterus. No generalized lymphadenopathy. There was bilateral pitting pedal edema noted up to ankle joint. Coming to the vitals, temperature 98 degrees Fahrenheit measured in the right axilla using a digital thermometer. Pulse rate was 118 per minute, regular in rhythm, large volume pulse with the collapsing character. No radioradial or radiofemoral delay. All peripheral pulses felt equally on both sides. Respiratory rate was 38 per minute. Abdominothoracic type of respiration. Saturation was 99% with oxygen support. Blood pressure measured in all four limbs using an appropriate size cup in lying posture. In upper limb, 120 per 20 millimeter mercury comes under 90th to 95th centile. In lower limb, 160 per 20 millimeter mercury comes under more than 99th centile. Here, the difference between the upper and lower limb BP is more than 20 millimeter mercury. Here, so the Hill sign is positive here. Coming to head to foot examination, head appears to be normal in size and shape, hair normal, no dysmorphic facies noted, eyes and ears are normal, oral cavity normal, no dental caries, chest and trunk are found to be normal, and extremities are normal, no joint swelling or any restriction of movements. Skin, there is no rashes or subcutaneous nodules or petechial hemorrhages or subungual splinter hemorrhages suggestive of infective endocarditis. Other clinical signs I was able to found was elevated JVP, which was 7 millimeter mercury, and collapsing pulses, and Hill sign positive, Corrigan pulses present, and pistol shot sounds heard over the femorals, and Durosis murmur was present over the femorals. Coming to anthropometry, this child weighing about 35 kg, which comes under 25th to 50th centile according to IAP chart. Height is 152 centimeter, coming under 75th to 90th centile according to IAP chart, which was normal for this age. In body mass index, 15.5 comes under 10th to 25th centile according to IAP chart, that was also normal. And upper segment and lower segment ratio was 0.9:1, which was normal for this age. And arm span length ratio was 0.9, which was also normal. According to SMR staging, breast stage 2 development and pubic hair stage 1 development in a pre-pubertal state, according to the age. Coming to the examination of cardiovascular system, on inspection, chest wall found to be elliptical and bilaterally symmetrical, no deformity. Apical impulse seen in left 60 intercostal space, 0.5 centimeter lateral to midclavicular line. Hyperdynamic precordium was noted. No precordial bulge. Trachea found to be in midline, appears to be in midline, and visible pulsation present over the epigastric and suprasternal region. No scars or sinuses or dilated veins over the chest wall. On palpation, apical impulse position confirmed, felt in left 60 intercostal space, 0.5 centimeter lateral to midclavicular line, hyperdynamic in nature, and tracheal position confirmed by palpation in midline. No palpable P2 or no palpable P2, no parasternal heave, and no thrill. Coming to auscultation, on auscultating over the mitral area, first and second heart sound heard, soft in nature, high-pitched, soft-blowing pansystolic murmur of gray 3, which was radiating to the axilla and back, heard well with the diaphragm of this stethoscope, better heard during expiration, and gallop rhythm was noted. On auscultating aortic area, first and second heart sound heard normally with soft in nature, high-pitched early diastolic decrescendo murmur heard at left third intercostal space on the end of expiration in sitting position. In tricuspid area, first and second heart sound heard with the high-pitched pansystolic murmur of gray 3 heard with reduced intensity. In pulmonary area, first and second heart sound heard normally with no murmur. In respiratory system examination, work of breathing was found to be increased with bilateral R&3 equal with normal vesicular breath sounds, no added sounds. And per abdomen examination was soft and tender hepatomegaly was present, liver span of 14 centimeter, spleen not palpable. Coming to the central nervous system examination, higher functions are normal, cranial nerves are normal, and motor and sensory system also found to be normal. No cerebellar signs, no involuntary movements, no meningeal signs, and bilateral fundus was normal. Coming to the summary, this 11 years old girl child, who is a firstborn child of second degree consanguineous parentage, developmentally normal child, immunized up to the age, belonging to a lower socioeconomic status, admitted with impending respiratory failure with immediate antecedent history of migratory polyarthritis with fever of 15 days duration, followed by symptoms of congestive cardiac failure with significant past history of sore throat. On clinical examination, found to have a peripheral signs of aortic regurgitation with auscultation finding reveals features of moderate mitral regurgitation with severe aortic regurgitation with congestive cardiac failure without any signs of infective endocarditis or pulmonary hypertension. So I would like to consider the following diagnosis of a case of acute rheumatic fever with moderate mitral regurgitation and severe aortic regurgitation with features of congestive cardiac failure without pulmonary hypertension or signs of infective endocarditis in sinus rhythm with anemia.
Okay. So, Madam and Dr. Vinod, please go ahead and you can go back to the initial
back to
slide of examination and then we come back again. Okay. See, overall, it is correct that before we went for the examination, we discussed something called rheumatic reactivation versus acute rheumatic fever, isn't it? Okay, there is nothing to discuss in this slide. This slide is just straightforward finding. Next one. Pulse, you have very clearly told everything. Rate, rhythm, volume, character, everything. Okay. Collapsing pulse, you have said. There is tachycardia, you have said. Okay. And respiratory rate 38 per minute and saturation normal with oxygen. All these are fine. Next. Now, blood pressure, we have to be very careful and we need to have the appropriate cuff. Otherwise, we need to always overdiagnose. We need to either overdiagnose or underdiagnose in children. Like if you take the cuff and bend it into half and try to measure the blood pressure, it's not appropriate. Many times it's better to take the help of the machine because the currently machines come with at least 3 inflatable cuffs for at least 3 group of children. And the machine blood pressure is many times better than the manually what we see by sphygmomanometer because there is a reproducible. Now I'm going to ask one question. You may not be able to answer. How does the blood flow in the body from the aorta, from the ascending aorta to arch to descending aorta, or the other way? From the ascending aorta arch to descending aorta, isn't it? See, ascending aorta blood pressure is 120, descending aorta blood pressure is 160. That means the blood has to come back, no? The lower limb pressure is 160, and the blood has to come back from lower limb to the heart. So what is the problem? Have you ever thought about this? Why this is occurring? What is this phenomenon called? Why the lower limb blood pressure? Normally, is the lower limb blood pressure higher than the upper limb blood pressure? Yes or no? Answer is yes. Now that is exaggerated in aortic regurgitation. Now, why does it occur? You please can read. It's a very interesting hemodynamic. Okay. Now, next. Go to the next one.
Muscle mass.
What muscle mass? Okay, if because there is higher muscle mass in the thigh, you are falsely recording higher blood pressure. That's what your explanation. No, that's not the explanation. Even if you put in your arterial catheter once in the radial artery and another one in the femoral artery, you'll have the higher pressure recorded, systolic pressure recorded in the femoral artery. Okay, there's a phase lag. It's all related to the augmentation of the pressures at the iliac bifurcation. Okay, this augmented pressure reflected wave. The reflected wave generates a pressure which adds on to the existing pressure and gives a higher pressure locally. And there is a creation of pressure at the level of bifurcation of the iliac. And there is a lag, phase lag. If you see the curve of the ascending aorta, the arterial pulse curve, and the arterial pulse of the femoral artery, both will be different. And the peaking of the pressure also will be slightly different. Okay. So the when you blindly see this, we always think that the blood has to flow from an area of higher pressure to lower pressure. But here it's not, because they two are occurring at a slightly different phase of the cardiac cycle. And this higher measured pressure is a locally created pressure because of the reflected waves. Okay. Okay, next.
What does this sign tell you about the severity of the aortic regurgitation?
She mentioned in that further all the peripheral signs of aortic regurgitation. Now, one thing I would like to ask you, if you are getting all these classical peripheral signs of aortic regurgitation, is it an acute or chronic aortic regurgitation? Very simple question. You are getting very excellent. You have mentioned some 5 signs of aortic regurgitation. Is it an acute regurgitation or chronic aortic regurgitation? It has to be a chronic aortic regurgitation. It cannot. In acute aortic regurgitation, patient dies if you don't treat very fast. Okay. Suppose somebody has had a tear in the aortic valve. Okay. Or somebody has an infected endocarditis of the aortic valve, comes in severe AR. Unless you do aortic valve replacement, he dies. He will have low cardiac output. He will not have a single peripheral sign of aortic regurgitation because the end diastolic pressure will be so high. LV end diastolic pressure will be 30. Aortic diastolic pressure also will be 30. So you won't get the signs of collapsing pulse and things like that. Subacute presentation, it could be. But when you have such all classical peripheral signs, it has to be a chronic aortic regurgitation. Okay, go to the next slide.
The severity of aortic regurgitation, if a Hill sign, the pulse pressure difference more than 60 millimeter mercury is significant. And so,
Don't say significant, it is severe.
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 It's severe. Oh, see, whenever you are getting peripheral signs, it's severe. All these peripherals you mentioned only seen in head nodding, carotid dancing, whatever you mentioned, Corrigan's pulse, all are severe. Not
Sometimes moderate AR you can get these peripheral signs, but this kind of Hill sign definitely it's a severe AR. More
no.
than 60.
Now, do you have any other way to explain me? Suppose you can still argue that, sir, it is only subacute AR. Because of this, I'm getting all the exaggerated signs of AR. Do you have any finding? You do have one finding, which you mentioned in your final diagnosis. I am committing it as chronic aortic regurgitation, but you don't want to bring in chronic aortic regurgitation. You want to say that it's only a subacute aortic regurgitation. You did have another finding which can color the findings of aortic regurgitation. Okay, can you get collapsing pulse without aortic regurgitation? Yes or no?
yes, sir.
Can you get collapsing pulse without aortic? Yes. Commonest causes any high volume pulse.
Any high
volume pulse.
So
Is there a reason for this child to have high volume pulse?
what's your adjunct in your diagnosis at the
Was
end?
anemia.
Anemia.
Yes. So if there is significant anemia, that's going to cause relative volume overload of the entire cardiac circulation, and it's going to further cause collapsing pulse, and it can exaggerate the findings of aortic regurgitation. Let us have that in our back of our mind. Okay. Okay. Next slide. Okay. Here, is there anything to discuss? Anyone can discuss. Otherwise, next slide, please.
Oh, so now at this point of time, the extremities were normal, is it? When she was admitted, there were no
Yes, sir.
joints.
There is no swelling of joints.
Okay. So where do you look for subcutaneous nodules?
Sir, over the occiput and spine and extensor aspects of limbs.
Okay.
Have you seen
Where
one?
else? What about vertebrae?
Yes.
Occiput
She said
and
spine, madam. She said
Spine,
spine.
she said.
Yes.
Fine. Iliac crest. We can question the other two learners also, sir. We are
No,
waiting.
that's
Dr.
what-
Gayatri and Mahesh.
Yeah. See, whenever we ask question, does it mean only the presenters should answer? Others also should
I think they are waiting. I thought they didn't know like they could also answer like.
They also should chip in, and they should also either agree or disagree with the presenter's answer. Let us have it like that. Either they say, yes, sir, we also think so, or we can give some other answer. Okay. Now, when you say JVP, I don't know what is asked in pediatric examinations. I think pediatric examiners are not very particular on JVP. Now, rather than telling 7 millimeters of mercury, which is very difficult to come to a conclusion, it's better if you say how much it is elevated. And whenever you want to be very particular about how much it is elevated, the typical position described in olden days. Nowadays, at least in cardiology, we don't insist on that. Like you go to the 45-degree leaning position and go to the junction between sternum and the vertebra, draw a line. Nothing is needed. In sitting position, do you see JVP? If you see elevated JVP, how much is elevated above the clavicle? That's all. You can say JVP is elevated 3 millimeter above the clavicle. You are not mentioning about the pressure. Yeah, elevated JVP is an elevated JVP, irrespective of the number, whatever you are going to tell, whether it's 7 millimeter or 5 millimeter or 10 millimeter, it is elevated JVP, and patient is having right heart disease. Okay, right heart failure in addition to the left heart failure. Now, more importantly, so here when you say JVP is elevated, better you mention the waves were visible when the child was sitting 3 millimeter above the clavicle, and subsequently you should try to mention about the waves. If you're not sure, you can mention, I'm not sure about the wave which is elevated. You should try to mention whether it's a predominant A wave or V wave, whether both the waves are seen or only one wave is seen. Because based on that, again, further some conclusion can be arrived at. In our examinations, most of the time, the examiner will not cross to subsequent examination without going through JVP. They'll discuss half an hour about JVP. So JVP is very important, gives us a lot of clues. Other things are all fine.
Sorry, how did you get that 7 millimeter mercury?
That's what. How did you arrive at that number?
7 centimeters of water, no?
Even then, that 7 number and all is very arbitrary.
Yeah. Actually, you can calculate. There's a formula. You multiply 0.4 or 0.7, I think. But usually, traditionally we tell centimeters of water only. You just measure above the sternoclavicular head in sitting posture. That's how we do now.
She just used 2 scales and she measured. I don't know why she put it as mercury.
I converted into mercury by
how did you do that?
into 0.7.
0.7, okay.
Okay, then it's okay.
Okay,
Usually young children, we don't insist on JVP, sir. But when it's a school-going child around 9 and 10, we in pediatrics also, we insist on JVP if they are cooperative and developmentally normal, sir.
Right. Good. Next
just
one.
mention a centimeter of water only. You no need to convert to mercury.
Yeah, let us stick on to the conventional descriptions one. Yeah. Next, please. Okay, here there is nothing to discuss, isn't it? A slightly underweight child, but otherwise fine.
Do you have to mention, madam, in all pediatric cases, do you mention upper span, lower span, upper section?
This child was looking a bit of marfanoid, sir. That she didn't mention in the general examination, but then she had arachnodactyly. So that's why we asked her to mention the arm span.
Okay, good.
So what are the lesions, cardiac lesions you get in marfan now? Deviate.
Aortic root dilatation, dissection.
And?
Mitral valve prolapse.
Mitral valve prolapse. Okay.
Mitral valve prolapse.
Okay. So we can deviate in any way depending on what you present to us actually.
Now let us go one by one. Now chest wall is elliptical. What do you mean by elliptical? Okay.
Anteroposterior diameter of the chest wall is less than the side lateral diameters of the chest wall.
Got the point. So whenever you want to say that child has a COPD kind of chest, barrel chest, okay, you want to differentiate from say that is elliptical chest. Bilateral symmetrical is very important, and then the no deformities is fine. Now the apical impulse says it's in the left 6 intercostal space lateral to the midclavicular line. That means there is cardiomegaly. What do you mean by hyperdynamic pericardium?
The apical impulse was visible for more than 2 spaces.
Yes, so that means
that's a diffuse apical impulse. Hyperdynamic and heaving, how do you differentiate?
Now, whenever we say about apical impulse, we are expected to commit whether it's a LV type of apical impulse or RV type of apical impulse. Now, is it LV type of RV or see, how do you say it's a diffuse apical impulse or localized apical impulse? If you see a prominent bulge during systole only in one intercostal space, or at the maximum just an adjacent intercostal space, it's a localized apical impulse. If you see more than one intercostal space, it's a diffuse apical impulse. If you are not able to clearly locate the apical impulse, it's diffuse apical impulse. And if you want to say a diffuse apical impulse, then it is more in favor of an RV type of apical impulse, and the cardiac enlargement is because of the right ventricle. On the other hand, if you are able to see a localized apical impulse, then this cardiac enlargement is because of the left ventricular enlargement. So now here your description is LV apical impulse is cardiac LV type of apical impulse. Whenever we say hyperdynamic pericardium, it simply means there are dilated chambers behind the chest wall. That's all. That's what we expect. It's a dilated chamber. Suppose volume, excellent. Suppose somebody has aortic stenosis, there may not be a dilated chamber and pericardium may be quiet. Somebody has mitral stenosis, you may not see any pericardial activity unless there is a pulmonary hypertension. Okay, so whenever you say hyperdynamic pericardium, you are going to expect regurgitant lesions. That's what we are trying to say, or conjunctivitis left reactions. No pericardial bulge and the hyperdynamic pericardium. Can you just connect these two? Imagine that child has been having hyperdynamic pericardium for about 6 months or 8 months or 1 year. There would be a pericardial bulge. Your this commitment of no pericardial bulge means that this hyperdynamic pericardium is relatively recent.
Duration of illness.
This is relatively recent. That's what the understanding between these two. Okay, trachea and midline has no real significance in cardiology. Again, visible pulsation in epigastric region means what? Visible pulsation in suprasternal region means what?
Because of aortic regurgitation, the pulsations were felt over the suprasternal.
What causes the pulsations in the suprasternal region? It's the arch of aorta. Okay, suprasternal pulsations, if you are seeing, either there is a severe aortic regurgitation or there is aneurysm of the arch of aorta. Arch of aorta. What causes pulsations in the epigastric region? Is it left ventricle? Is it left ventricle in the epigastric region? It's a right ventricle.
Right ventricle.
If you are seeing epigastric pulsation, that means there is right ventricular enlargement. So this line you were telling me that child also has right ventricular enlargement. This one presentation, child has left ventricular enlargement, child has suprasternal pulsation, meaning thereby there is something to do with an aorta. Child has right ventricular enlargement. Biventricular enlargement is the thing, clinical thing we have given based on this one slide. Okay, next please.
Sometimes in severe AR also you can get epigastric pulsations without RV enlargement. So
that will be abdominal aortic pulsations. So that's why they used to say that becomes more of cardiology. See, you have to, that comes in palpation, and whenever you commit about the epigastric pulsation, whether it's a below upward pulsation, that is the pulsation coming from above or the pulsation coming from below. The child is lying and you are putting your fingers over the abdomen and trying to feel the pulsations. The pulsations are coming and hitting at the tip of your fingers. That means it's a RV pulsation. The pulsation is coming from below. It is an aortic pulsation. So severe aortic regurgitation causing epigastric pulsation will be coming from below. Okay. Palpation, again apical impulse, confirming the same thing. And when you commit about hypodynamic versus, again, what do you mean by hypodynamic in nature? There is more better way of explaining this impulse than committing it as hypodynamic. What is hypodynamic? And the next question
What
is,
happens to the pulse? Once you palpate, how long it stays in your finger and goes, depending on that, you will classify, arbitrarily into heaving and hyperdynamic. How is that? Which will stay longer and which will just touch your hand and push off. Heaving and hyperdynamic.
Hyperdynamic stays for longer.
How?
Heaving,
just the other way around.
If the apical impulse is sustained, it lasts longer during systole. If the apical impulse is sustained, it is heaving apical impulse. That indicates there is resistance to the left ventricular outward tract. If the apical impulse is very prominent, but it is ill sustained, then it is hyperdynamic. So hyperdynamic apical impulse, commonest cause is, as you said, anemia or aortic regurgitation or even mitral regurgitation at times. If it is heaving apical impulse, it has to be either aortic stenosis in children. In actually older individuals or adults, it's systemic hypertension.
So don't get confused. Just remember, aortic stenosis, the LV has to press against the aortic valve to increase the cardiac output, so it takes a longer time. So heaving you will get in conditions like aortic stenosis, and then hyperdynamic will be the volume overload lesions. No need to get confused.
Right. Are you sure there was no thrill? I expect that there would have been a diastolic thrill based on the findings, whatever you mentioned. No? When you had so much of peripheral sense of aortic regurgitation, most of the time you also have a diastolic thrill. And to feel the thrill, unless you look for the thrill, we will miss the diastolic thrill. Systolic thrills are commonly easily felt. Diastolic thrills, we have to look for it. You have to use the base of the phalanges, not the palm. You have to use the base of the phalanges, put over the chest, ask the child to lean forward, hold the breath for some time, then listen, you will get a thrill. Okay, you can try it tomorrow. Okay, next. Madam, again, one question, and others examiners in this hall. Even now, are we following this rule that in every area you have to say S1, S2, S1, S2, S1, S2? Because when you say S1, we are predominantly mentioning or dealing with mitral valve. Okay, S1 is M1 and T1. T1 is hardly here. When you say S1, it is mitral valve related. When you say second sound, we are going to assess the second sound in the pulmonary area. Because P2 is mainly here in the pulmonary area, and all other areas we hear the A2 only. So whether the P2 is same as A2 or P2 is lesser in intensity than A2 or P2 is louder than A2, all these can be committed only in the pulmonary area. So what we expect generally that, or what we were expected to tell is, commit about S1. Is it soft or not? Or is it normally here or not? Commit about second sound. Is it normal split, wide split, reverse split? And what about P2? Is it same as A2 or less than A2 or louder than A2? And we not mention about the area. Only when you come to murmur, we have to mention about each area. Like mitral valve, as I said, one murmur, aortic area, other murmur, tricuspid area, other murmur. So having heard this, doctor, can you just tell us about the heart sounds in this child? Only heart sounds, S1, S2.
So others also please answer.
Others, yeah.
Others can answer. Mahesh and Gayatri can help Vinita.
Still, how S1 is first?
அவங்க வீடியோ எல்லாம் கூட
Here
ஸ்டாப்
the
பண்ணி
S1
வச்சிருக்காங்க
is
மேடம்.
soft in this child.
வீடியோ ஆன் பண்ண சொல்லுங்க. Other, yes. See, let me tell you how you should tell here is S1 is soft. S1 is soft indicates both the thing to be valvulitis or there is mitral regurgitation. Okay, S1 is soft. Then second sound. Second sound is normally split. A2 is softer than P2, meaning thereby there is no pulmonary hypertension. Okay, then no S3, no S4. Here you mentioned about S3. So you should mention that S1 is soft. Second sound is normally here, normal speed. P2 is softer than A2. S3 is here in the mitral area. No S4, no additional sounds. So this completes the description of other sound. No additional means either any pericardial knock or these, that, all the, it includes all the additional sounds. In case of mid-systolic leak, we can hear, I mean, in case of MEP, we can have mid-systolic leak. If it is a bicuspid attic or something, you can have an aortic ejection click, or there can be pulmonary ejection click and pulmonary hypertension. All these things will come. So when you say no additional sounds, all these things come. So first heart sounds, how do we say? S1 is soft. Second sound is normally here. Normal A2 P2 gap is here. P2 is softer than A2. S3 is here in the mitral area. There is no S4 or additional sounds. Then you come for the murmur. Okay. Then now, based on these heart sounds itself, we get an idea. Okay, this is what the patient is having the lesion. Now we are going to hear about the murmur. And the murmur your description is a very pakka description for the mitral valve. Like it's a high pitch, soft murmur, and here during expiration. And why do you hear the murmur better in the expiration?
In a left side murmur, left side heart lesions, producing murmurs are better here during expiration. So because of while expiration,
so why the right-sided murmurs are better here during inspiration?
Because of increased venous return.
Increased venous return.
Increased venous return occurs. Lot of blood flows through the valves, and where does the blood go and lodge? It lodges in the lungs. So during expiration, the reverse occurs. The entire blood gets pumped into the left side. So same answer. The answer is there is a relative higher stroke volume during expiration in left-sided chambers. That's the answer. Okay. Aortic area, again, I expect that there will be an ejection systolic murmur also in the aortic area. If you have this much of aortic regurgitation, which is clinically causing so much of peripheral signs, then the LV volume has to be high. Imagine, suppose the usual LV stroke volume is 70. This child's LV stroke volume will be 150. Each time 150 ml of blood will pump from the left ventricle. 70 goes into the aorta and goes as the cardiac output. 70 ml comes back to the left ventricle. So 150 goes in, 70 goes to the systemic circulation, 70 comes back. When this 150 ml of blood goes through the normal aortic valve, that has to produce a murmur, isn't it? That has to produce a flow murmur. So I expected that in the aortic area, there will be a 2/6 or rather even 3/6 ejection systolic murmur, probably localized well here only in the aortic area, not conducting or radiating anywhere. And then there will be this ejection murmur, diastolic murmur, whatever you described. And if you have mentioning about any ejection murmur in the aortic area, you should also mention whether it is here to the carotids or not. A functional murmur, whatever I said, generally not here at the carotids or not transmitted to the carotids. On the other hand, even if it's a 2/6 murmur or 3/6 murmur, if you hear in the carotid also very well, that becomes a point in favor of associated aortic stenosis. Okay. Now that murmur is missing here. Tricuspid pad. Now, when you have a very loud mitral regurgitation murmur, which is heard even at the back, the same murmur can be transmitted to the tricuspid area also. Now, my question is, how did you differentiate this tricuspid murmur from mitral murmur?
In tricuspid area also the same murmur with reduced intensity. Sir.
Then that can be only a conductor murmur, no? So my question is, do you want to say this is the tricuspid regurgitation murmur or not?
There is no any increased intensity during inspiration, sir, in tricuspid area.
Okay. So to avoid this confusion, what we can say is that mitral area, when you mentioned about pansystolic murmur here at the back and also up to the tricuspid area. Finish it off. When it comes to tricuspid area, no additional murmur. Finish it off. If you say like that, then the examiner says that, knows that, okay, you are not going to commit as tricuspid regurgitation. But when I heard it for the first time, I thought you were committing that there is an tricuspid regurgitation also. That's why this question came. Okay. So pulmonary area, of course.
The correct way to differentiate is mitral murmur from tricuspid is like you go follow the inching method. So you start from the apex and go slowly inch by inch towards the tricuspid area. If it is the same murmur, it will decrease intensity like this one. If it's a separate tricuspid murmur, it will decrease in it. Then you will hear a louder murmur again. So
Again, you will again hear another louder murmur. And as you have rightly said, tricuspid regurgitation, pansystolic murmur can be when the ask the child to gradually increase the respiration, inspiration. The moment you say mooche immediately, not like that. When gradually do, you can clearly see the murmur going up and then coming down. You can easily understand. Left-sided murmur may not be that much clear with the respiration, but right-sided murmurs can be very well differentiated by the inspiratory movement. So here it is not a separate murmur. So right now, based on auscultation, you have committed only two murmur, a pansystolic murmur and the AR murmur. Even in the mitral area, there could be a MDM if you hear properly, because older child you might get. Even if you miss that, that is fine. But definitely the child is going to have an ejection murmur in the aortic area, which should have been there. Okay. Okay. Now next. Respiratory system normal, abdominal, there is hepatomegaly. And because why should there be an hepatomegaly? See, there is raised JVP, isn't it?
Right outside.
Okay. Raised JVP means, see, that's what I'm again saying. If the child did not have tricuspid regurgitation, there can be still right heart failure because of pulmonary hypertension. Acute aortic regurgitation can cause pulmonary hypertension. Acute mitral regurgitation also can cause pulmonary hypertension. The pulmonary hypertension need not cause distension of right ventricle, but that will cause increased diastolic dysfunction, and there will be prominent A wave in the JVP. On the other hand, suppose if the tricuspid valve also has one way, tricuspid regurgitation has occurred, that can cause raised JVP, that can cause hepatomegaly also. So hepatomegaly is more common in patients with right heart failure with tricuspid regurgitation than without tricuspid regurgitation. If you want to give importance to hepatomegaly, then probably that was an additional TR murmur. Maybe let us see the echo report. But going by clinically, if the hepatomegaly is significant, what you have said is tender hepatomegaly, that is commonly seen only when there is significant tricuspid regurgitation. Without significant tricuspid regurgitation, you won't get this much of tender hepatomegaly. Okay, splenomegaly is very uncommon.
In this case, if you have a tricuspid regurgitation, you will have either an organic or a functional. So most likely an functional will be much more common, like that is due to pulmonary hypertension, than when it's an organic tricuspid regurgitation due to rheumatic fever. So you have to be very careful when you're commenting about tricuspid regurgitation and telling no pulmonary hypertension and a rheumatic fever.
Now, what did you understand by what Dr. Vinod's comment as functional tricuspid regurgitation and organic tricuspid regurgitation? Others can answer.
primary involvement of the tricuspid valve will cause organic tricuspid regurgitation, sir. Functional tricuspid regurgitation is due to the severe pulmonary artery hypertension. There will be a regurgitation in the tricuspid valve.
Okay. Which will have prominent murmur? Functional TR or organic TR? Functional TR will have a prominent murmur because there is a lot of turbulence will be there because of the pressure difference than the organic TR. Now, there are 4 valves in the heart. Of the 4 valves, mitral valve, and we have tricuspid valve, we have pulmonary valve, aortic valve, and all. Which is the valve which is most commonly affected by the rheumatic fever and the rheumatic heart disease?
Mitral valve.
Next to that,
Aortic valve.
next to that.
Then tricuspid valve. Least is pulmonary valve.
Okay. Why is this order being followed? Is there any relation why this order is being followed by all the patients? Majority of the patients. See, there are some children or there are some patients who come with more involvement of aortic valve than the mitral valve, but majority will have more of mitral valve than the aortic valve. Why is this order being followed? See, rheumatic fever is an inflammatory disease, isn't it? Rheumatic fever is an inflammatory disease. The degree of damage to the valve is proportionate to the inflammation which they are undergoing. Now, of the 4 valves, almost all the tissues in our body, they are at constant wear and tear. There is a minimal inflammation going on in all the tissues, whether joints or eyes or skin, everywhere, right? Now, in heart, it is much more because it is mechanically active. The only organ which is highly mechanically active in our body is heart. And the valves, they do undergo wear and tear on daily basis. They wear daily and they get repaired daily because of the mechanical effect. Now, of the 4 valves, which valve is having the highest hemodynamic stress? Aortic valve, mitral valve, pulmonary valve, tricuspid valve. Which of the 4 valves is having the highest hemodynamic stress? That means it is facing very big pressure. Which valve?
Aortic valve.
Aortic valve. Okay. Any other taker? Any other answer? All are agreeing with the same aortic valve? No. Suppose, let us say this child is normal. This child is normal. Suppose this child was normal and his aortic pressure is 100/70. Okay. Got my point? The child is normal. Aortic pressure is 100/70. What's the pressure faced by the aortic valve? What is the function of aortic valve? It closes in systole or diastole? Diastole. What's the diastolic pressure? 70. So aortic valve faces a pressure of 70. So which valve faces the pressure of 100 or 120?
Mitral valve.
Mitral valve. Okay. See, mitral valve faces the highest pressure of all the 4 valves. That faces the systolic pressure of the left ventricle. Aortic valve faces the diastolic pressure of the aorta. Tricuspid valve faces the systolic pressure of right ventricle, and pulmonary valve faces the diastolic pressure of the pulmonary artery. So you can clearly correlate with the hemodynamic stress. The valve with the least hemodynamic stress is the pulmonary valve. So the normal wear and tear mechanisms in the body is also least for the pulmonary valve. So when the rheumatic fever affects the heart, it affects the heart as such. But wherever the inflammation is more, the affection is more. So the valve which has the maximum ongoing minor inflammation, wear and tear is mitral valve. That's the reason why you get mitral valve involvement as the maximum. Next will be the aortic valve. Third will be the tricuspid valve, and the least will be the pulmonary valve. So if you want to commit organic tricuspid valve disease, that has to be a rheumatic heart disease, not acute rheumatic fever. You can say there is rheumatic reactivation. So in this case, if somebody tries to drag your leg by committing or making you to commit as organic, better not to commit. Because somebody has to develop organic tricuspid valve disease, it has to be very long, more than 5 to 8 years kind of, disease should be there. And more than 1 episode of rheumatic fever should have been there. So that it would have affected mitral valve, it would have affected aortic valve, and then it has affected the tricuspid valve also. So organic tricuspid valve disease is more common in those who have had recurrent rheumatic fever. So that is more commonly seen in adults than children. Okay. So that's a good point for discussion regarding the so-called organic tricuspid valve or the functional tricuspid valve regurgitation. Okay. So next slide. Okay, CNS normal. Here basically you want to say it is chorea or not. Now, what is peculiar about what is the name of this chorea in occurring rheumatic fever?
Syndenham's chorea.
What is anything peculiar about this chorea and the common chorea? What you see in for other etiology?
Disappears with sleep.
Yes, yes.
Associated with emotional ability and aggravating factor is emotional stimulus and disappeared while sleeping.
Okay. So it also doesn't leave any sequelae. It's also a benign phenomenon. It can last for a month or it can last for years. At times it can last for even 2 to 3 years, but subsequently it goes off without leaving any scar in the brain. The only place where it leaves the scar is in the heart. Can it
What's
occur
the-
during pregnancy?
Pregnancy.
Can it occur during pregnancy?
What is the correlation between chorea and pregnancy? It abates or increases. What's the correlation between chorea and acute phase reactants? ASO, CRP, and ESR and chorea.
Phase reactants will be normal
It has a
Why?
latent
Why?
period.
because longer latent period will be there for
Latent
chorea
period.
to manifest.
An acute manifestation or chronic manifestation?
Chronic
Chronic
manifestations. So acute phase reactants will be normal.
What is subclinical carditis?
Only
There
echocardiographic.
will
Echocardiac evidence of valvulitis will be there in one.
Okay, can you mention few echocardiographic evidences?
That
To
will
say
be,
it's a subclinical mitral regurgitation, there will be a jet in at least two views with with a jet length of more than 2 centimeter at least in one view, with a jet velocity of more than 3 meter per second at least in one view. In aortic
And
regurgitation, there will be a jet length of more than 1 centimeter is significant.
a pansystolic jet in mitral regurgitation and pan-diastolic jet in aortic regurgitation.
How is the recent criteria different from the original modified Duckett-Jones? What are all the ways in which it is different? This 2015 criteria.
Carditis
On the endemicity.
classified.
One by
One
one,
person,
it
please.
is
Just
very
raise your
important.
hand and answer.
This question is both theory. It can be asked in theory also. It can be asked in practical also. Very important. Clinically also very beneficial, useful. One of you can answer.
Evidence of subclinical carditis is included in the major criteria according to recent modification of Jones. It classifies the area into low risk areas and high risk areas. In low risk areas, carditis, polyarthritis, erythema marginatum, subcutaneous nodules, and Syndenham's chorea is considered to be a major criteria. In areas of high risk, carditis and polyarthralgia or monoarthritis, Syndenham's chorea, erythema marginatum, and
You just tell the difference
substituting.
between both. You don't have to.
Differences alone.
And you please tell how you differentiate between low and moderate to high risk, because numbers also they can.
How do you differentiate? On what basis you differentiate into low endemicity and high to moderate risk
A
areas?
place where the incidence of acute rheumatic fever is more than 2 per 1 lakh population, 1 lakh children is considered to be a high risk zone. A place where incidence of acute rheumatic fever less than 2 per 1 lakh is considered to be a low risk zone. And based on the prevalence of rheumatic heart disease, if the prevalence of rheumatic heart disease more than 1 per 1,000 population, it is considered to be a high risk zone. Prevalence less than 1 per 1,000 population is considered to be a low risk zone.
That's actually not entirely correct. So basically, what you tell is less than two per lakh of school-going children, 5 to 15, and less than 1 per 1,000 of all age rheumatic heart disease is low risk, and others are moderate to high risk. So you just define low risk, and others are moderate to high risk. So one is for the rheumatic heart disease for the school age rheumatic heart disease, one is for the all age prevalence. This thing. So 2 per lakh, and less than 2 per lakh and less than or equal to 1 per 1,000. So that is low risk. And then others are moderate to high risk. Then you go to only the essential differences between both. You don't have to tell this thing Korea for both of them. You don't have to tell everything. Just tell the differences between both in major and then in minor.
In major criteria, monoarthritis or polyarthralgia can be taken in account in high endemicity area, and subclinical carditis can be taken as account. In minor criteria, in high endemicity area, there will be a fever of 38 degrees Celsius can be taken, and elevated inflammatory markers like ESR more than 30 and CRP more than 3 can be taken as account.
Correct. So these are correct. And again, it's mentioned that many times these children get some medical attention and get the treatment. For example, very commonly they get some kind of NSAIDs, and they are going to blunt the development of arthralgia into arthritis. So that also has to be considered. And just because arthritis has not occurred, it doesn't mean there is no rheumatic fever. All these things have been very well described and mentioned, and it's very relevant to us also. Okay, go to the last slide. So last slide. Now here, having discussed, okay. Now again, there could have been further discussion. How will you say mild, moderate, severe, and things like that? Now here, the except murmur, there is a dilated LV which can occur both in AR and MR. There's a pansystolic murmur. If you had mentioned about but you did mention about LVSC, again that can be because of AR or MR. If there was a mid-diastolic murmur here, the apex, that could have favored the diagnosis of severe MR. Okay, just to say, in addition to say, moderate MR is fine, severe AR is fine, congestive heart failure is fine. But only thing is it only an acute case of rheumatic fever, or is it an acute rheumatic reactivation with underlying chronic rheumatic heart disease, especially because of the aortic valve disease? If you are getting so much of aortic valve signs, sorry, madam, dog is barking in the background. Sorry, it's my dog. It's not my dog. It's my neighbor's dog. Go myself mute. So this can be,
use the mic,
rheumatic fever, or it could be rheumatic reactivation in the background of a chronic rheumatic heart disease. So fine, and maybe we can further go on for X-ray and echo.
Kannan, if you use the mic and the plug, then the dog noise will not be heard.
What are the two clinical signs where we can know it's an acute rheumatic fever from a chronic rheumatic heart disease?
This child presented with acute presentation of fever, migratory polyarthritis.
Generally, the case is coming. Based on which two clinical signs you know it's an acute rheumatic fever?
Carditis and arthritis.
I'm asking cardiac findings.
There will not be any signs of pulmonary hypertension.
No. You don't understand the question. So how do you know it is an acute rheumatic fever? So you know that it's a pancarditis, right?
Yes,
so if pericardium is involved, if you have a pericardial friction rub, it means it's a acute carditis. And number two is, if either is an onset, if a patient is having chronic rheumatic heart disease, if it's a new murmur which is coming or change, if it's a chronic follow-up your patient, you know the intensity of the murmur. If the intensity of the murmur has changed, increased, then you know it is a acute rheumatic activation. So either the presence, if a patient is having a chronic rheumatic heart disease, you know the patient well. If he comes with a pericardial friction rub, it is a rheumatic activation. Or the presence of a new murmur or change in the intensity of the existing murmur, then you know it is a rheumatic activation in the face of a chronic rheumatic heart disease. But for that, you must know the patient. You must be in regular follow-up. You must know what is his murmur intensity exactly and what the murmurs he has. Then only you'll be knowing. So the clinically how to do. Then you have your investigations. Based on your investigations, all this ESR, CRP, ASO, and all you can find out. But this is clinical way before your investigations come.
Okay. Do we have any investigations here?
Yes, sir. Just project the investigations.
Yes, please go ahead.
This is the X-ray taken on the day first of admission. Here it's a chest X-ray AP view with a proper positioning taken in the line, proper positioning with the skin and soft tissue found to be normal, with evidence of cardiomegaly in the form of straightening of right heart border, probably
No,
a
no, for the
left
want of
atrial
time, we can just rightly tell the findings and go quickly because we have less time. So there is cardiomegaly.
with
Is there
pulmonary
pulmonary
edema.
edema?
Lung fields, what do you see?
Pulmonary edema, pulmonary congestion.
Okay.
Pulmonary edema, basically. Frank pulmonary edema.
And then you can see shadow in shadow, indicating that there is biatrial enlargement. I can see two shadows on the right heart side, isn't it? Where to the right of the spine, you can see two shadows. And the way the heart has enlarged is LV type of enlargement. Okay, that's significant LV enlargement. All these things can be made out. Okay, next one.
ECG of the child. Here the findings are it's in sinus rhythm with normal axis. There's no evidence of any LV strain pattern or LA hypertrophy in ECG.
அது ரொம்ப சின்னதா இருக்கு. We will not be able to
There was no prolongation of PR interval also. That was conspicuous by its absence in the ECG.
So what is the first thing you notice actually? It's all a very low voltage complex.
Low voltage complexes.
That is assuming that the standardization is correct. So when you think of low voltage complex, you must think of either a pericardial or a myocarditis. You must think of.
So X-ray has given some suggestion, but ECG hasn't given any clue. Okay. Now, okay, next.
Blood investigation showing neutrophilic leukocytosis with anemia of 9 grams per deciliter, dimorphic anemia with relative neutrophilia, with platelets being normal, and renal function test and electrolytes are normal. In liver function test, there is an elevation of significant elevation of SGOT and elevated ESR, CRP, and ASO titer positive, with 3 consecutive blood cultures found to be no growth, and throat swab normal flora only detected. Urine analysis, there is no evidence of RBC or proteinuria. In echo findings, tachycardia during the study was noted, and good biventricular function with ejection fraction of 68%, with mitral and aortic valve thickening noted, with dilated left atrium and left ventricle, with moderate mitral regurgitation with severe aortic regurgitation, and coronaries were normal and no vegetations.
Any mention of pulmonary hypertension in this echo?
Yeah, what about tricuspid valve? What about tricuspid regurgitation? What about pulmonary hypertension? And we have not received any explanation for the raised JVP and hepatomegaly in this echo. Okay, so the raised JVP and hepatomegaly means there has to be some pulmonary hypertension, tricuspid regurgitation, things like that. Now here, a furthermore description of the valve is needed, whether to commit this as a chronic regurgitation or not. But the thickening itself is indicating it's some kind of chronic. In acute rheumatic fever, there will be edema of the valve leaflets, but not very visibly thickened. There may not be any visible thickening just like that. So if the echocardiographer has definitely committed a thickened valve, then that is more of a chronic nature. But more specific finding will be if there is any kind of doming of the valve, whether it's aortic valve or mitral valve, it's a chronic lesion. If they have mentioned about any kind of commissural fusion of the mitral valve, that's a chronic process. If they mention about subvalvular pathology, it's a chronic process. So if it is only acute rheumatic fever, none of these things will be there, and it's better for the echographer to mention that there is no thickening, there is no commissural fusion, there is no subvalvular pathology to suggest a chronic pathology like that. So
sometimes
here still
you can see a beading and nodularity of the mitral valve. That means it's an acute mitral valve pathology. If the echograph looks quite this thing for it.
Again, a pericardial effusion, we thought about, we discussed about low voltage complex. No, pericardial effusion is not mentioned. So not mentioning is an important finding. No pericardial effusion, like no vegetation is an important finding. No, they have written here. I'm surprised that the echocardiographer mentioned about coronaries, normal coronary. That's good. Again, it's not so relevant, but still is very good. No pericardial effusion mentioned. Thickened pericardium may not be noticeable by echo. It's difficult. But pericardial effusion is easily noticeable by the echo. Okay, so so going by all these findings, one thing is very sure that there is still ongoing acute inflammation.
Okay, still ongoing inflammation. Whether it's a rheumatic reactivation or the same acute rheumatic fever, still there is ongoing reactivation, though the arthritis component has disappeared. Though the arthritis component has become passive, the carditis component is still persisting, and this child has to be aggressively treated, and there is a very high chance that this child will go on to develop a rheumatic heart disease. This is not going to regress. Many times during acute rheumatic fever, we see moderate to severe MR, which will last only for a week or 10 days, and 3 months follow-up and 1 month, 6 months follow-up, they would have become mild MR. Okay, but here, going by the duration of the illness, still ongoing kind of inflammatory activity, echo already showing thickened valves, this child is going to go for rheumatic valve disease fully. Okay.
Sir, I think on follow-up, they had a re-echo done. Vinita, you can tell, no, what happened to the
We did a
recent
serial
echo done last week when the child came for follow-up.
That echo showed a mild pulmonary artery hypertension, sir, but no tricuspid regurgitation was found.
Okay. I didn't notice the hemoglobin. You mentioned pallor, isn't it? So
9
pallor
grams
could be
per.
okay, right. So pallor could be due to heart failure also many times. A low cardiac output also can cause pallor. 9 grams is anemia basically. So we have to keep up the hemoglobin more than 12 in all heart patients, not by giving transfusion, but by giving other methods. So by nowadays the IV iron therapy is very beneficial. All the children will have so-called anemia of chronic disease. Absorption may be poor, but IV iron therapy is really coming in hand to improve the hemoglobin status reasonably earlier. So I think, say any comment from coaches and any doubts for the students you can ask. So what we discussed was history-wise how to analyze the history. History should be classified into 4 components. First one is explain the presenting illness. Then you mention about the left heart symptoms, present or not. Then mention about right heart symptoms, present or not. Then history of complications like say stroke, infected endocarditis related history, whatever you said. Then history of etiology. Then history of treatment. So if you classify in this way, you won't miss anything. In the history of treatment, if you say this child was seen 1 year later by a doctor and was advised to take a monthly injection, again that's an important history. And history wise, the mother says the child is taking a tablet daily and after which he passes a lot of urine, that's an important history. So history of treatment. So classify the history like first component will be presenting illness, then explaining the presenting illness, left heart symptoms, history of right heart symptoms, history of complications, history of etiology, and history of treatment. Then subsequently go for the past history and things like that. And the way you tell the history to the presenter, that you'll be pulling the presenter towards your diagnosis rather than going one history this way, one history the other way. So this be a kind of clear, you should be dragging the patient or the examiner towards your diagnosis. And when you examine, if some component of the finding is not going in hand with the your clinical history, you can always tell the examiner that there is a disparity between what I got by history and what I see clinically, rather than trying to modify the history, because it's very important. If you are genuine and if you are kind of true to your history, all examiners will forgive. See, examiner is never unhappy to see you make mistakes or to miss something. Examiner doesn't want you to be perfect and make full length of correct diagnosis. No, they want to know whether you are able to assess it properly in an unbiased manner with a reasonably good diagnosis. Okay, so good case and well presented. Thank you for the opportunity.
Thank you, sir. It was a pleasant experience for all of us to hear from you.
Yeah, can you stop slide sharing, please?
Yes.